Hello everyone, welcome. My name is Susan and I'm with Memorial Hermann Orthopedic and Spine Hospital. I'm the spine nurse navigator and I'd like to introduce a couple of our physicians here. We have Dr. Mark Persarin. He's an orthopedic spine surgeon. He's affiliated with Memorial Hermann Ironman Sports Medicine Institute. And then we have Dr. Sam Basian. He's our physical, medical, and rehab physician. He's also affiliated with Memorial Hermann. And then we have Dr. Bohani. He is a primary care sports medicine physician, and he is also affiliated with Memorial Hermann Ironman Sports Medical Institute. And we'd like to start off speaking with Dr. Persarin. I have a question about, how do I know if I need back surgery?
Sure. So that's probably a very important question to start off with, and the real truth is the vast majority of patients with back pain or back problems do not require an operation. The sort of isolated instances where somebody may present and need surgery right off would be somebody with like a tumor, infection, instability, something bad of that sort. But most people don't require surgery, and certainly surgery shouldn't be the first line treatment. And that's why we have physicians like Dr. Bajani and Dr. Sebaskin to help us. They're obviously very busy physicians that we use to try some non-operative treatment first prior to proceeding with an operation.
Okay, thank you. And so we'll have a few other questions. Let's start off with you over here. We have, when should I be concerned about back pain?
Sure, that's a great question. I think in general, if it's affecting your life, so if it affects the activities that you do, it affects your relationships and your desires in life, I think then it should really be evaluated and addressed to see if there are any options that can help you out. And it might not be to get you 100% pain relief, but we would want you to resume the activities that make you happy.
Right, and it's all about function, right? When you're concerned is when your inability to function in the things you really want to do, your goals of, and everyone's different. Certain people just want you to do the basic life activity. We call changes that you can actually physically see, what we call neurological deficits. If you're having problems, for example, going to the bathroom, having numbness or tingling that's persistent, if you feel weakness or you're limping as a result of just some sort of muscle changes, or you have fevers, chills, or significant pain that keeps you up at night, those are your biggest warning signs that there's something more significant, more impactful going on that needs to be addressed quicker than your typical back pain.
Right, absolutely. And I think often we get patients where the family member would come and tell us, oh, you look really uncomfortable, you can't do the things you want to do. Those are other reasons. If somebody else is noticing that you're not moving around well because of it, or you're limping, because you might not know that you're weak, but if somebody else looks at you and says, you have a limp, I think it's very important that you get checked out to make sure there's nothing we can do to help you out.
Agreed, yeah.
Thank you. So who should they see first when they have back pain?
Yeah, so, like Dr. Persarin said, the vast majority of the statistics, up to 90% of the time, back pain is what we call functional mechanical back pain, which really doesn't require any kind of surgical or procedural intervention. Seeing your primary care doc, seeing a physiatrist or a sports medicine physician will probably be your best first line to get the majority of pain, get the pain addressed, so at least you have 50% improvement in the pain within that first 4 to 6 week window is what we're looking for.
Right, and often what we would recommend are probably ancillary services, maybe therapy, maybe simple changes to your routine, nothing very aggressive to see if we can just do the simple things to get people back.
Yeah.
It doesn't have to be very involved.
Yeah.
Okay. What percentage of patients that you see need back surgery?
So if you really look at it from the primary care part, it's really, it's for initial back pain, it's almost less than 10%. You really have to get pretty aggressive with some of the stuff we talked about earlier as far as things that are concerning for back pain, to really be able to say that you need surgery. A lot of times, like Sam said, it's all about physical therapy. It's about getting the functional status back and strengthening up your core, strengthening up your back, and loosening up your hamstrings, and getting the pain control you need with the medications. And like I said, 9 out of 10 times at that 4 to 6 week markers, which is where you really are supposed to have expectations for back pain to recover, you should get that recovery.
Right, I would agree. It's a very small percentage that need surgery. I do some procedures, so the ones that make it into my clinic sometimes have already done the 4 to 6 weeks, and then likewise the ones that end up with Dr. Prasaran have already completed both of our what we do, and they might have a higher percentage, but in average I would say it's very, very low.
So would you recommend, a patient coming to see you first, so that way you could evaluate them before going out to see the surgeon?
Yes, I think that would be the most effective way to treat patients. Why? Because I think the simple things might work, and if they work, then everybody's happy. The surgeon, doesn't have to focus on the non-surgical stuff and can really do the surgical stuff, and we can do the non-surgical stuff, or the primary care can do it, or people that do the non-surgical stuff, because the majority will get better.
Yeah.
And there are issues that we come across, and there are some patients that come into our clinic that might need surgery, and we would get the appropriate things to get them to the surgeon quickly. So there are cases when we might pick up on somebody that needs surgery.
Correct. I mean, more often than not, like you said, the surgeon needs to be involved when the surgical conditions are met. But like as a primary care sports doc, we could get the medicines and the therapy going. If there's criteria for imaging that needs to be done, we can address that at that time. And if simple stuff doesn't work, or there's something a little bit more with regards to pain control, then getting over to you to do some of the procedures, the injections, the facet injections, the soft tissue injections, or an epidural injection to try to get them that pain relief, so that they can continue on the conservative stuff to once again get back to where you need to be at that mark that you want to be at.
Okay. Let's see. When do you think that they would need to have the imaging done?
Yeah, I mean, it's so if you really look at the latest guidelines from the American Academy of Orthopedic Surgeons, I know you're not my society are pretty much the same. Imaging is actually not indicated. It's actually it's not indicated to be done at the initial visit unless you had those criteria we talked about earlier that show severe neurological or systemic deficits. You don't need to have X-rays done. You don't need to have an MRI done. The European study that came out last year took a significant number of patients from every decade of life and did X-rays on them, and every single person above the age of 50 had disease in their back without any symptoms, and that's 100% of the time. So when someone tells you and you're over the age of 50, you had an X-ray showing degenerative disc disease or spondylosis, those are your two most classic terms, they actually just really, without the pain, it means absolutely nothing. With the pain, it still more often doesn't contribute to the pain itself. You have to do the other stuff first to be able to say that this is where the pain isolates, and this, I'm gonna...
Absolutely, yeah, I think I would agree. If you image everybody that walked in the door, you're gonna find a lot of stuff that's not relevant. So the recommendation really is not to especially get an MRI on everybody. I think there are certain patients that we do get the imaging, and if they have neurologic deficits, I would probably want to know what is causing that deficit. And the only way to tell that without opening up is to get an imaging study like an MRI. If we're gonna plan a procedure or a surgery, I think it's very prudent to get imaging. And X-rays have a role, and then MRIs have a role too. The X-ray or a CT scan can show you the bone very well, whereas an MRI can show you the nerves and other things that might pinch structures. So the two together are usually what we use when we try to come up with a procedural plan. I might need the X-ray to see the bones, because if I'm planning a procedure, and I might need the MRI to show me the pathology that's causing the weakness. And they would come in hand. However, most patients don't need that because we're not doing anything different. I think both of us would agree probably that if the imaging is not going to change your management, we probably would
You don't need it. And I know that there are a lot of ancillary services that are out there that will want to get X-rays and show alignment and show, are you lined, are you twisted, are you malrotated? At the end of the day, there's no data supporting that X-ray radiographic images without any of the neurological changes that we just described actually changes the outcome as long as you do the proper treatment plan.
What about sports? So in traumatic injuries.
Yeah, and so
that.
traumatic injuries in sports is a little different, right? When you have younger athletes, you always have to worry about different disease states. So it depends on the age of the patient, the type of trauma, the type of sport they're playing, and really what the exam shows us. In younger kids, we do worry about pars defects, and that's the one big case where the X-ray is going to give away the answer because it does change the management because it's technically considered a fracture. So once again, the exam and the history dictate the imaging. The imaging does not dictate the treatment plan unless the history warrants the imaging.
Okay, thank you. Now, how long would a flare-up last in your back?
Yeah. So realistically, let's be realistic here. And you could say anyone that's had a non-traumatic back flare-up, the twinge in the back from trying to pick up something or the twisting motion. I usually tell my patients 4 weeks. I mean, that's a fair goal. You cannot expect this to go away within 4 weeks. I mean, and that's I keep referring to this greater than 50% improvement within 4 weeks. That's what the literature suggests, and that's what my practice has been showing. I mean, I would imagine.
Right, it's very similar. Yeah, I would say I usually tell them weeks, not years. Weeks for a flare, and then the expectation that if we get over this flare, it might come back again. That's another thing I usually, even if I did a procedure, got them through the flare, whatever it was, this is not an isolated event, and it might come back, but if we know how we fixed it the first time, we would do that again, and usually that's exercise.
Yeah.
So usually doing the core strengthening earlier can help it resolve quicker. So if you had your first flare and it lasted for a few weeks, if you got on the exercises that worked the first time, 1 or 2 days into the second flare, you might not need that 4 weeks to get it to resolve again.
Yeah.
And that's kind of what we see. But I would say weeks.
Weeks.
Yeah.
Okay. Is there anything that you can do to help prevent back pain?
Yeah, so that's the big one, right?
Yeah.
It's all about figuring out how to prevent it from happening the first time, and equally how to prevent it from happening after it happens the first time. And I think the lifting techniques. We always talk about active lifestyle and maintaining a good regimen as far as your physical activity, strengthening up your core, keeping your hamstrings and quadriceps loose, keeping your back alignment straight. Good posture is always important. Those things come in really big as far as preventing it from happening. But once it happens, we've talked about doing the physical therapy, getting over the hump, but the more important part is not just doing the physical therapy to get you past the pain, but it's to continue those exercises so that the flare-ups don't happen as frequent, and if they do happen, don't happen as intense as the first time.
Right, and once we've treated a patient with back pain and they're comfortable with their home exercise program, that's usually the precursor of a flare. Is if you did your exercises 3 days a week, the first thing that might be obvious if you did them the same time every day is your range of motion will be lacking.
Yeah.
That often comes before the pain. So if you did it every day and you can't bend down as far, I would strongly recommend to increase the exercises because it's probably the sign of a little irritation coming on. Your range of motion goes away, and then a few hours later you get the pain.
Yeah.
So if you keep up with the maintenance of that program is very crucial.
Yeah.
The maintenance of your healthy lifestyle would help everything. And then the lifting technique is very important. That can cause a lot of pain. So we usually recommend using your knees and not bending forward to lift items, trying to go down with your knees first so you're not bending over and lifting things heavy. Even something simple like putting a baby into a car seat when you have to reach over with the baby, that can load discs, which can
Correct. And then pushing, not pulling, that's a big one. I mean, a lot of people tend to pull, the classic move, everyone moves and everyone tries to move boxes around and whatnot, making sure that if you have a dolly or have some sort of cart that you're transporting heavy items, make sure you push it so that you can actually have better control rather than pull it, which means you're reaching behind, getting the rotation to the back and stretching out those small spinal muscles that put you at risk for further pain and for the pain deficits as a result. Yeah.
And then the other These are great questions, and these should be things that you address with your therapist too. When
Yeah.
you're finishing, when we write therapy, the last session or two should be home exercise and preventative
Yeah.
things. And if you didn't, if you finish your course of therapy and you didn't get that, it's very reasonable for me to put someone back for a couple sessions to make sure they're comfortable
Yeah.
and they know the do's and don'ts.
Yeah, it's all about goals, right? As we talked about that at the beginning, your therapy has 3 phases. 1, pain control and range of motion. 2, strengthening. But 3, it's your goals. What do you want to be able to do that you were able to do before that you can't do now? So getting through those 3 phases of therapy is extremely important. Like you said, that last page is extremely critical because you want to get back to where you have been, not where you are, where if you're pain-free. You want to be able to do everything you've been able to do and not have any issues.
Okay. So when you send the patients out to physical therapy, how long do they typically end up being there doing those, exercises? Is it just a few weeks or longer?
I think few weeks is appropriate. I mean, everything has, I think, thresholds. So you want to start off, if you look at what the literature is suggesting, what I guess our practice the same way is,
Yeah.
4 weeks I think is a good number.
Yeah.
2 to 3 times a week for 4 weeks. That gives you at least an idea of where you're going to be at 4 weeks. If you're not significantly better, 50% is considered a low threshold. If you're not 50% better, then that means you probably are not going to progress well in therapy. You should be coming back to see the physician to figure out the next steps, especially if you're at 50% lesser improvement, or if you start taking significant amount of analgesics, pain medications, or whatnot to help control the pain. That means your therapy may not be the right thing for you at that point, and we may need to start considering the imaging, the procedures, or further intervention. But you've seen cases where you could be at like 50 to 60% at 4 weeks, and you might just need it 2 3 extra weeks to kind of get you over the hump. But therapies, we're just talking just basically with the physical therapist. That doesn't include home exercises. I mean, home exercises should be going on irrespective of that after you complete your
Right.
course with the on-site therapist.
That was my next
Yeah.
question. And, they should also continue doing them on their own, correct?
Right.
Yeah. You don't go to school without doing the homework.
Yep. And as far as, medication and things of that sort, is that not always your first defense to go to that?
So I think this is a great question
Yeah.
because everyone, let's just system out. You can get the Tylenols, the ibuprofen, the Motrins, the leaves. You can, let's start this rest. You can get steroids. You can get narcotics. You can get muscle relaxants. You can get Valiums. There's a lot of different medications you can use. But here's the truth. The truth is, like I said, most of the time it's simple stuff. The Tylenol, the ibuprofens usually can do it. If there is a strict muscular component causing a spasm, yes, maybe a short course of low-dose muscle relaxants. The Valiums, the Xanaxes, and all that stuff that we tend to use to relax the muscles really have shown to be no impact. Steroids you should not really take unless you have neurological deficits or failure of therapy with the over-the-counter stuff. And that's a discussion you need to have with the physician. And then narcotics, once again, any stepwise therapy, you need to progress up to that stuff. And I will tell you, 1 out of every 15 to 20 require that in my practice. I mean, you really don't need get that far as long as you can get the pain under control. And you can always remember, Tylenol, Motrin can be taken together. So if you alternate them back and forth in the right regimen, you should be able to get fairly good pain control initially, and then be able to taper down quickly.
Yeah, I would completely agree with that. Most patients with the Tylenol, the anti-inflammatory medicine, plus or minus a muscle relaxant at the start, are able to get through their flare, their pain. And then some, very few, need something stronger. And often those are ones that maybe have something different, like a bad, neurologic deficit with it, or a fracture or something different. And then the medicine can be used to help you through therapy, because I think the medicine is unlikely to cure the issue or solve the problem. It's really the core strengthening that'll resolve the pain, because that offloads the structures that hurt. So if you time the medicine around, one, you need to sleep. So if you time the medicine at night, that's useful.
Yep.
And number two, if you time it with your therapy, then you might be able to do more. And that'll allow you to get the results that you're looking for. Similar to when we do procedures, it's not the procedures that we do. I rarely just do the procedure and then send them home. I usually recommend therapy after the procedure, because the procedure is going to wear off. It's like a Band-Aid. But if you do the procedure and you do therapy, then you end up with far better, more durable results. And that's what we're trying to do.
Yeah, it's all about, pain control is obviously the first thing on everyone's mind. And I think but realizing that pills are just a patch. And we didn't even touch on the fact that heat,
Yeah,
ice,
modalities.
biofreeze,
Yeah.
stem, TENS units, over-the-counter lidocaine patches, Asper cream. There's a lot of stuff that now is out on the shelves that can get you a very good effect and get you a similar outcome than having to take the prescription strength stuff. So
Right, even I think you use
acupuncture,
for
yeah,
some
dry
patients.
needling was
Right.
a big component of physical therapy. So there's a lot of different things besides what we call the RXs that you
Right.
can use to get control of pain. And I think it's important to recognize that.
That's good. Well, I don't have any other questions right now, and we can go and see if we have any questions online, maybe. If anybody has any questions here. And let's see here.
Yeah. And I think, the theme of this presentation, I kind of want to say this while we're looking up some questions, is back pain is probably the number one musculoskeletal complaint that we see in the primary care office. It is the number one complaint that we initially see in urgent cares, and it's a significant amount of dollars spent towards it. I think it's almost $1 billion last year alone spent to back pain. So I think it's important to recognize that getting early pain control the right way, starting the therapy, and preventing future episodes, I think is the mainstay of what we're trying to preach here.
Right, yeah, it's education on
Yeah.
what to expect and what is out there and what can happen. And then if you're concerned, just, you should really talk to your provider
Yeah.
and make sure that they counsel you on what your expectations are.
I think that's it. Do you guys have anything else to add?
I think we're good.
Yeah.
We've summed it up on our end.
Okay, well, thank you, Dr. Sambasian and Dr. Bohani, for joining me today. And thank you guys for also watching us live today. And have a great day.
Thank you.
Thank you.